I first would like to thank you all for allowing me to come to your unit-based council meeting, and a special thank you to Angie and Jennifer for allowing me to come in. And I'm first going to start this presentation off by asking you guys 3 rhetorical questions. So just kind of think about the questions in your head, but you don't have to answer them out loud or anything. So if your patient was to ask you what specific medications that were in their inhaler, would you be able to properly answer them with the right answer? My next question is, when you take care of your patients of a morning, do you hand them their inhaler and then just move on to do the next thing? Do you actually watch them use their inhaler? And finally, if they were using it incorrectly, do you feel like you would properly be able to educate them on the proper way to use their inhaler? If you're like me, most of the answers to those questions I would have said yes, but I wouldn't have been that confident in my answer. So I hope that this presentation kind of helps you guys become more confident with saying yes to those questions. And just a side note, I notice a lot of times when I give patients their inhaler, I'm kind of moving on to the next thing. I'm getting their pills together or whatnot, and I don't really pay attention to them when they use their inhaler. So hopefully after you've seen this presentation and heard what I have to say, you might change your way of thinking on that and also kind of pay attention to how they use it. This presentation started out when I contacted Angie, and I had to come up with a lecture as far as what would be beneficial for our unit. And so we decided that COPD would be a good topic, especially since our unit is in the middle of this education program. After that, I tried to determine how best I could bring that topic down. And so what I did was I emailed 25 of you nurses, and I received quite a few responses. And interestingly enough, all of the responses I received, everyone said that they wanted information on COPD inhalers. So there you have it. So that brings me to my learning objectives. I'm going to talk about the various classes of COPD inhalers, how they work, specific medications in each one, the side effects, different combination inhalers, and finally, step by step, how to properly use each type. So just a little bit of underlying information about COPD. It's very prevalent in our country. It causes 4 million deaths per year. It's projected to be the 3rd leading cause of mortality by 2030. And a lot of money is spent on this COPD population. And in fact, in 2005, $32 billion was spent on COPD. But when I was doing this research, actually what I found most interesting was the amount of people that don't know how to use their inhalers correctly. And in one research study, up to 91% demonstrated incorrect inhaler technique, which I thought was pretty crazy. And in fact, 25% of those patients were not educated by either doctors or nurses. So that tells me we have a lot of work to do to get these patients fully educated so that they don't come back and see us in the hospital with their exacerbations. So there's 4 different classes of COPDs. The first 2, beta agonists and anticholinergics, each have short-acting medications and long-acting medications in them. And then there's the corticosteroids, and finally the combination products. So I provided you guys a handout because I'm going to be throwing a lot of medications at you, and I do think it can be overwhelming, so you can kind of use this to refer to, but also after this presentation you can kind of use it in your practice as a nurse to look at and refer back to. So the first category are the beta agonist bronchodilators. These work on the beta-2 receptors, and so they promote smooth muscle relaxation, and they cause the bronchioles to dilate, which increases the airflow and allows patients to breathe easier. So here's my question for you guys. Out of the medications on this slide, which one do you think is the first-line treatment for acute bronchospasms?
Albuterol.
Albuterol, that's the right answer. What is the difference between albuterol and Xopenex? Anybody answer that? No? Okay. Albuterol is definitely the first choice option. The reason for that is actually both of these medicines work within 5 to 15 minutes of a patient coming into the hospital with an exacerbation. So if your patient comes in and they're short of breath and they're wheezing, more than likely they're going to get albuterol. Now the reason they might get Xopenex is because albuterol has a lot of side effects, such as jitteriness, tremors, tachycardia, palpitations. So Xopenex would be a better choice for those patients who have underlying cardiac disease. So that's something to consider too. The problem with Xopenex though is it is slightly more expensive, so that's a disadvantage when the patients are leaving the hospital. but they're both good rescue inhalers that we see a lot on our unit. Now there's 3 main long-acting beta agonist bronchodilators, and again, these are more the maintenance medications, whereas these are the rescue inhalers. So these are going to be given more twice a day, routinely. And we'll talk about those in a minute. Okay, so the short-acting bronchodilators. The 2 main ones out, again, are albuterol and Xopenex. There's several different names for albuterol, such as Proventil, Ventolin, ProAir. So you might hear any one of those names. And I have the side effects, again, listed there. And another common one, too, is sleep disturbances. So if you hear your patient saying they aren't sleeping well, it could be related to the albuterol they're receiving. So as you all know, this is an MDI. And I'm actually going to explain to you guys how to use this inhaler, and I'm actually going to demonstrate it, too, so you promise you can't laugh. Okay, so the first thing you're going to do is you're going to take the cap off, and you're going to shake it for a full 5 seconds. Research says that 5 seconds is the best way to, the amount of time that it should be shaken. Once you take that cap off, you should exhale completely. Once you do that, you should have a tight grasp from your mouth around the inhaler. So there should be a tight seal. Nothing should escape. The most important part is when you fire that inhaler. So in other words, that when you fire the inhaler and you push the canister down, it can't occur before you push it down, and it can't occur way after the inhalation. It must occur as soon as that inhalation begins, or just immediately after. It can't be too much before or too much after. And finally, after you take that breath, you have to hold it for 10 full seconds. And I think once you guys watch me do this, you might realize that our patients really aren't doing this correctly. So this is my mom's Symbicort inhaler, and don't worry, it is clean, and it's empty. So, but I'm not actually going to push the button down, but just kind of watch when I do it, and you'll notice when I do it based on my inhalation. So I'm going to shake it for 5 seconds. I'm going to breathe out. Does anybody think their patient actually does it like that?
No.
I would say no. When I actually was researching this, I was surprised at how little our patients probably do this correctly. It was hard for me, though, even holding it for, I think I did it like 7 seconds, 6. But if you can hold it, the inhalation for at least 5, that's the most beneficial. And holding it at the end, like having your inhalation be over 5 seconds is beneficial, and then holding it at the end for 10 seconds is what the research says is best. Anyways, does anybody have any questions on that? Okay. I found some really interesting statistics, and it said that even if that technique is absolutely flawless, the patient's only getting 55 to 60% of the medication. So over a third of that medication is staying in the back of the oropharynx. So that also tells you that we really have to be teaching our patients how to properly use their inhalers. And something else that was interesting, that when that inhaler is fired, if you're doing it even a half a second early, the amount of medicine that reaches the actual lung decreases by 34%. And if you fire that inhaler over halfway through the inhalation, the amount of medicine that's reaching the patient's lungs decreases by 41%. It's kind of crazy. So really something to think about when you're teaching your patients how to use their MDI. And something else too, if they're not using their MDI correctly, something else you can use is a spacer. Just keep that in mind. Because a lot of our patients are elderly and they don't have the coordination to fire that inhaler at the exact right time. Oh, and also if they need to have a second puff, then some articles I found said 20 to 30 seconds in between the puffs, and some of them said 1 to 2 minutes. Okay, so these are the long-acting bronchodilators. Ceravent, Borvil, and Brovana. As you can tell, Ceravent looks like Advair except it's green. So it has the dose counter right there. Always make sure when you give your patients their inhaler, if it does have a dose counter, that it doesn't say 0. The thing that makes this different than a DPI or than an MDI or meter dose inhaler is this is a DPI. So it means dry powder inhaler. So the medicine's inside. So that medicine has to get through the inhaler and out of it and into the patient's lung. So the breath should be more forceful and deep. Whereas if you notice with the MDI, it was more long and deep and drawn out. This one's more forceful and deep. But still, it should be held for 10 seconds afterwards. So that part doesn't change. Floridil, has anybody given that?
Mm-hmm.
I have, but it's been a while. But the thing about that is it's like Spiriva. You put the pill inside, you push the buttons on the side, that punctures the pill, and then as you breathe in, it vibrates, and that's how you know that they're using it correctly. I brought up Ravana. It's not an inhaler, but I feel like we see that a lot on our unit. And it is only by nebulizer, but again, it's a long-acting bronchodilator. So it's given twice a day, and all these, again, are maintenance drugs. Any questions on that? Okay. The next category are the anticholinergics. The great thing about these is that they do have a lot more minimal side effects than the other ones I just mentioned. So that includes the headache, dry mouth, mild cough. It is rare, but they can also get glaucoma if the medicine reaches their eyes. And there's two main ones. The short-acting maintenance anticholinergic is the Atrovent, and the long-acting is, of course, Spiriva. We give that quite a bit. But how these work is they block the parasympathetic nerve reflex, which normally that causes your airways to constrict, but by blocking that reflex, it actually helps dilate them. So it does have a bronchodilator effect as well. It just works differently than the other group because the other group's working on those beta-2 receptors. But the nice thing about these is they also reduce the amount of mucus. So as far as Spiriva, you put the pill inside again, as we all know, you press the green buttons, and you want to hear it vibrate. So as long as you hear that vibrate, then you know the patient's using it correctly. The thing about Atrovent and Spiriva is you don't want your patients to be on both of those medicines at the same time. And I see that happen some on our units. I'm sure all of you guys have too. So if you notice that they're on one and the other, then we need to be contacting the physician to see which one he or she actually wants them on. Because again, they're in the same category. And this is a good time to bring up duonebs. Does anybody know what's in a duoneb?
Albuterol and Atrovent.
I knew you would know it. Albuterol is your short-acting bronchodilator. Atrovent, again, is your anticholinergic. Some research says that having those two together produces a better bronchodilation effect, and so that's why we see a lot of our patients on it. But I did find that that research is controversial. But I think that our pulmonologists probably think that's the case, that they do have a better effect than alone. And the thing about Spiriva that was interesting to me was there was this article published in 2011 where U.S. pulmonologists said that that was the most effective medication that they were prescribing for COPD. So I think that's why we see it so often, is because of that comment. The next category are the corticosteroids, and there's four main ones that we're going to discuss with these. The big thing about corticosteroids is they don't help dilate the bronchioles. What they do is they decrease the inflammation. So Qvar is one. I've never personally given Qvar, but that's what it looks like. It's an MDI. And then you have Flovent. Flovent is orange, so it comes in an orange discus or an orange MDI. And then we have Pulmicort and Azimex. Pulmicort is a flexhaler, so what that means is it has this knob, and you turn it all the way to the right and then all the way to the left, and then it's ready to use. And I brought up Asthmanex because it's mainly used for asthma, but it does have an off-label use for COPD as well. And I swear, every time I have a patient with Asthmanex, I never know how to use it, ever. I don't know if you guys have ever felt the same way. But I always give it to my patient, and I say, do you know how to use this? And I always pray that they say yes, because every time I forget. But I finally did the research on it, and what you have to do is, as soon as that cap is removed, it's ready to go. So as soon as you remove that cap, that dose counter goes down by 1, and then you can't really see it in this picture, but there's an arrow right there. There's an arrow, and that arrow should line up with that dose counter. So these are both breath-actuated DPIs, which means that as soon as the patient provides inhalation, the medicine is ready to go.
Okay.
Are there any questions on those?
Hang on a second.
The corticosteroids do have a lot of side effects. That's the bad part about it. They have they cause oral candidiasis or thrush, hoarseness, headache, cough, respiratory infection. So my question for you guys is at the bottom. If you knew these side effects, what do you think we should be teaching our patients to do after they take a steroid inhaler?
Mouth care.
Yes, mouth care. Rinsing the mouth out. We should absolutely be teaching them how to do that and to make sure that they do every time after a steroid inhaler. Now I know as well as you guys do that I've tried before to tell patients, rinse your mouth out after that inhaler, and they kind of look at me and say, oh, I've been using that inhaler for years and I've never had trouble, so why would I start now? And that's fine, but especially if we're initiating these inhalers, we need to know if there's a steroid in them so that they can rinse their mouth afterwards. And Mary Ellen, I want to bring that up too. She was actually the one that said she recently had a patient who was on a steroid inhaler and they developed thrush while they were on our unit in the hospital. And she said that patient was told that she had never been educated on rinsing her mouth out afterwards. So she would be in one of those 25% of those patients from that slide earlier that hadn't been educated by their doctors or nurses or physicians, whatever. Okay, the combination products. The great thing about these is it's two medicines combined into one inhaler. So obviously that's a benefit for the patient because they only have to use one inhaler versus two. But the research also says that by doing that, it produces a better bronchodilation effect with either the same or decreased side effects. So that's a huge benefit for the patient to help provide better control for their disease. So the first one is Combivent. This has albuterol and ipratropium in it, which is Acrovent. So it's an anticholinergic. So Combivent and Duonebs have the same medicines. One's just an inhaler, the other one's a nebulizer. You'll notice on all the other combination inhalers that I bring up that they're going to have the same type of drugs in them. So Advair has fluticasone in it, which is Flovent, and that's a what?
Steroid.
A steroid. And salmeterol. That's Ceravent, and that's a...
Bronchodilator.
That's right. So the Advair has the steroid and the long-acting bronchodilator all mixed into one inhaler. And again, it has the dose counter, so pay attention to that. And I think we all know that you push the side down, and the patient, when they're ready, should take a long, forceful, deep breath to get that medicine out. I was trying to do some research because I feel like our patients take a lot of Spiriva and Advair together at the same time. So I was trying to do some research to see which one should be used first and which one should be used second, and I really didn't find a lot of information on that. There was this one emphysema website that said the Advair should be used first and then the Spiriva, but that was really all I found. But for sure, if you have a patient with a long-acting bronchodilator and then a steroid, you always want to have them use that long-acting bronchodilator first.
That's what I was always told.
Yeah, and why is that?
Open them up.
Right. You want to open the airways up and then use the steroid so that can get into the opened up airways. The last three combination products are Symbicort, Dulera, and Brio Ellipta. This is actually Symbicort. It's an MDI, but the dose counter is on the top, not on the side or anything. This has budesonide in it, which is Pulmicort, a steroid, and then the formoterol, which is the Fordil. That's, again, the long-acting bronchodilator. This was actually approved for use in COPD in 2009, but you see that a lot given in asthma, like with my mom. And then Dulera, she also has that. Her asthma doctor told her to use Dulera when she felt the Symbicort wasn't working. So I'm not sure if Dulera is stronger or if it's just because it's a different alternative for her to maybe help differently. But it has the mometasone in it, which is the Asthmanex, the steroid, and then the formoterol, which is the Fordil, the long-acting bronchodilator. And then finally we have Brio Ellipta. That was approved in 2013 to be used specifically for COPD. There's no shaking involved with that. And actually, there was one in our conference room. What I found online was all blue. This one's gray. But you can see the dose counter here on the side. And all the patient, this is actually really easy to use. All the patient has to do is pull this down, and it's ready to go. Make sure that they don't cover the air vent. And the website said they should take a long and steady breath. And the box says they should hold it for 3 to 4 seconds after the breath. Everything I found online for all inhalers said to hold for 10 seconds, but this one actually says hold for 3 to 4. And what I found interesting was on Monday of this week I was watching TV and there was this commercial for a Noro Ellipta. Has anybody heard of that?
Mm-mm.
I hadn't heard of it, but it looks like this Brio Ellipta. And I did some more research on it, and it consists of an anticholinergic and a long-acting bronchodilator together. And in these combination inhalers that I've mentioned, none of what I said had the long-acting bronchodilator in it and the anticholinergic. So it's a different combination of a drug. And there was an article written in August of 2014 where the U.S. pulmonologist said that this Ellipta may soon take over Spiriva. So we might see that. The disadvantage with Anoro would be the cost, though. So we'll see what happens. The other inhaler that I found a lot for COPD online was something called Arcapta Neo inhaler. And you put a pill inside that one like Spiriva, and it's a long-acting bronchodilator. But I just wanted to bring up the inhalers that I feel like we see a lot in our unit, because again, I know it can be overwhelming to have all of these things kind of told to you at once. But we might see a Noro and Arcapta soon, I'm not sure. Okay, are there any questions that you guys have for me? Because I'm going to ask you a few. Any comments, stories, anything you want to bring up?
People always use their Advair, like they'll be like, oh, I was having difficulty breathing, so I used that one. I'm like, no. And then, you know, you have to go into the education process because they do think like that their combination products are their rescue inhaler, and that's not the case. They're like, oh, well, I carried my other one in my purse because that's where my doctor told me to carry. I said, yeah, because that's the one that works best.
No, so. Our patients, yeah, they really, I've never had anybody tell me that personally, but yeah, they absolutely need to be instructed on the difference between a rescue and an inhaler and maintenance. And most of the ones I mentioned were maintenance. It's just those ones in the beginning would be the rescue inhaler, like albuterol or Xovanex. So, this question asks you, more or less, how do corticosteroids therapy, how does that work? So do steroids promote bronchodilation, act as an expectorant, have an anti-inflammatory effect, or prevent development of respiratory infections? What would be the correct answer? C, absolutely. I can't tell you how many students and patients I've had say, oh, steroids help dilate the airways, and that's not true. They actually do not do that at all. They decrease inflammation. Okay, your patient Mary is complaining of a sore mouth. Upon assessing her, you notice white patches on her tongue. Which medications do you suspect this could be from? Select all that apply. B, E,
Oh, I thought so.
and D. B, D, and E? Yeah, that's correct. What you have to know about this and remember is that any inhaler that has a steroid in it can cause thrush. So those inhalers that have steroids are the ones we have to be educating our patients to rinse their mouth out afterwards. So ProAir is albuterol. That's just a short-acting bronchodilator. Pulmicort is a steroid. C-Combivent is albuterol and Atrovent mixed together, so that's not a steroid. D has the steroid and the long-acting bronchodilator in it, so they should rinse their mouth out after that one. And Advair also has the steroid and long-acting bronchodilator. So B, D, and E is correct. A nurse teaches the client about the use of a respiratory inhaler. Which action by the client indicates a need for further teaching? So which one would not be correct? C. Right. Because how long should they be holding their breath for after they inhale?
5 to 10 seconds.
5 to 10 seconds while they're inhaling, and then they have to hold their breath for 10 seconds after that. Okay. This is a little case study about George. He's a 70-year-old male. He comes to Deaconess, and then with COPD, he has shortness of breath, respirations or labor, and he wears 2 liters of oxygen continuously at home. And there are his vitals. So what medications do you think George might take on a regular basis at home? Any ideas?
Well, he probably has
Advair or Spiriva.
That's
and
actually
probably an albuterol.
That's
and
exactly
he probably
what.
has a breathing treatment too.
Right. The thing about this is since he wears oxygen at home, that means he has severe COPD. So just a little rescue inhaler is not going to be enough to prevent his flare-ups of his disease. He's going to need something more maintenance, more long-term. So I definitely agree with Julie's comment of Advair because it has a steroid and a long-acting bronchodilator in it. And Spiriva, like I mentioned to you, pulmonologists feel it's the most effective medication right now for COPD. So I think those combination of drugs would definitely be good for him. And what do you think you would expect for him to have while he's here in the hospital?
Duonebs.
Duonebs is a good choice. Of course, IV steroids, we know that. But Duonebs would be a good choice. Albuterol and Atrovent mixed together. And remember, if a patient has underlying cardiac disease, albuterol would not be a good choice, and a good alternative might be what? Zofenex. That's right. These are my references, and that's all I have for you guys. Do you have any further questions? I am going to pass out this little evaluation tool and a post-test questionnaire just to see if you guys, if I get a feel for if you guys understood this information. And that's it. Thank you.